All right, well, thank you everyone for joining us on this beautiful hot summer day for most of the country. We're glad that you're all here with us. I'm Norm Thurston, Executive Director here at NAHDO. And I wanted just to take just a second to recognize our 2023 NAHDO event sponsors. You can see those on the screen, and specifically our petabyte sponsor, the California Healthcare Foundation, and recognizing all of our strategic partners, the collaborating partners and the featured partners. And you can see those identified on your screen today. I am going to turn the time over to Charles Hawley, who is our Director of Projects, who will introduce today's speakers. Charles?
Thank you, Norm. So I will actually kind of turn around and introduce the next speaker. Let me stop sharing my screen real quick, because that will to make sure that I've got the info I need in front of me. So thank you. So first, I'm excited to talk a little bit today, to hear from some folks who can share a little bit of their experience working with Medicaid programs, data programs specifically, and some of the collaborations that have come out of that work. And so we have, starting out, we will have Pete Sheehan from CIVHC, the Center for Improving Value in Healthcare in Colorado. Pete is the Vice President of Client Solutions and State Initiatives for CIVHC, and he's going to tell us a little bit about the work that CIVHC does in relationship with with Colorado's Medicaid program. So Pete, I believe that you should be able to share your screen, but if you're not able to, let me make that work for you real quick. We can kind of see your screen, but we're seeing the presenter view.
All right, hold on. Is that better?
Yes, thank you.
All right, thanks, Charles and Norm. It's a pleasure to be here this afternoon. CIVHC appreciates the opportunity to share some of the things we've done with the state of Colorado, how we work with CIVHC, or how we work with Medicaid here in Colorado, and some of the experiences that we've had. So wanted to share a little bit about CIVHC before we jump in. CIVHC is an independent nonprofit. Our mission is to equip partners and communities in Colorado and across the nation with resources, services, and unbiased data needed to improve health and healthcare. One of our primary roles is to serve as the administrator of the Colorado All-Payer Claims Database, which we do in close partnership with the Colorado Department of Healthcare Policy and Financing, also known as HCPF, and I'll be using that acronym throughout the presentation. HCPF is the state agency that operates the Colorado Medicaid program, which is also known as Health First Colorado. And before we talk specifically about how we work with HCPF and Health First Colorado, just wanted to share a little bit about the parameters in which we are able to release data. The enabling legislation here in Colorado included the following direction: be a resource to multiple stakeholder groups, be available to state agencies and private entities who are focused on improving healthcare, make data, analytics, and reports from the Colorado All-Payer Claims Database available for a broad array of purposes within all applicable federal and state regulatory guidelines. While we provide data and analytics directly to HCPF and Health First Colorado, this mandate is foundational to our partnership with them. They take a broader view of how to use the data, which includes understanding data and trends across the entire Colorado population, not just the Medicaid population. So how do government agencies, including Medicaid in Colorado, use the data? There's a number of different ways. They use it to inform policy discussions, to understand and address community needs, to support state and federal government mandates, to measure results and assess changes in healthcare policies, as well as assess different conditions in Colorado's healthcare landscape, and to better understand cost and quality trends, including the commercially insured population, in addition to vulnerable and at-risk populations. We have a series of contracts in place with the state, with HCPF, and with Health First Colorado. And I wanted to take a minute just to kind of outline the main focus areas of some of these contracts, because it's kind of a proxy for the priorities and where the state is putting its dollars in terms of how to utilize data coming out of the APCD here in Colorado. First, we work closely with HCPF and CMS Region 8 to secure a 50-50 federal state match, which funds the Medicaid portion of the claims in the data warehouse. We also have an enhancements funding contract in place. This provides funding to enhance the database through quality initiatives and integration of new data and tools, such as census data and geocoding the entire database. New approved initiatives received a 90% federal match, and the state covers the other 10%. When initiatives go into maintenance mode, they are funded 75% by the federal government and 25% by the state. The Colorado General Assembly appropriates dollars to HCPF on an annual basis that they use to fund what we call a general fund contract, which supports operating costs, data intake, and a number of public reports each year. And finally, we have what we call a direct analytics contract, which is focused on providing reports and analytics that are used to better understand costs and utilization of services for the Medicaid population. Within the contracts I just mentioned, we provide dozens of reports and analytics to HCPF and Health First Colorado each year. Referenced on this slide are just a few of the non-public and public reports that we generate within these contracts. One example is the Affordability Dashboard, which is a tool we created to help HCPF and others understand costs and cost trends across a variety of views. We are able to slice the data looking at what we call a cost of care view, low value care, prescription drug rebates, alternative payment models, and Medicare reference-based pricing. So there's several different components to what we all rolled up into one dashboard that we provide back to HCPF. The cost of care portion of the affordability dashboard is filterable by payer type, by year, and by geography. So this is an interactive tool that we produced, and it is available on our website, and the link is right there at the top of the slide. We can show a percent of spending by outpatient, inpatient, professional, and pharmacy claims spend, as well as long-term care for Medicaid. We also provide total dollars spent, as well as average spending per person per year in each of the categories. And so what you're seeing here is it's just filtered by Medicaid. This is a 2021 view, and this is kind of a roll-up of all the things I just mentioned. Through our work with HCPF, we've learned that they have an abundance of Medicaid data. So when trying to answer the question, how does Medicaid use the data? What we've been told in a number of conversations is we have tons of Medicaid data. What's helpful for us is to understand views that go beyond the Medicaid data. They know what their trends and spending percentages look like, and our data validates much of what they already know about the Medicaid data. What they don't know is how those trends compare to what is happening in the commercial insurance world and how it's different from the Medicaid experience, and understanding why. Here we're showing the Medicaid spending trends by category in the top half of the slide. So you can see it's the Medicaid filter. Again, it's that 2021 view, but you can see multiple years of trends. And it's broken out by outpatient, inpatient, and professional claims, as well as the long-term care view. Most of this spend is relatively flat. with professional claims in the purple trending slightly upwards in 2021. Long-term care is at the top in gray. We don't track that on the commercial side, but we can show that portion of the spend. On the bottom is the same view for commercial. So we're showing professional, outpatient, and inpatient claims all trending down from 2019 through 2021 on that spending by category. But the pharmacy spend is trending upwards. And so that's a different view of what the Medicaid experience was over that time period. That time period was inclusive of the pandemic. Medicaid roles expanded in Colorado. The commercially insured population may have relied more on managing their health by adhering to their meds and avoiding office visits and inpatient care during that time. Just a couple of thoughts. But Medicaid is interested in understanding how their trends compare to what's occurring outside of Medicaid, trying to get a total view of what's occurring within the state and how they can filter and set this to play with different views according to their priorities. Again, this is still within the affordability dashboard in the cost of care section. We can break down the data by geographic region within the state, helping HCPF understand where costs are higher and providing insights into what might be driving those costs. In Colorado, we've got three main geographic areas. The rural mountains in the west, in the western slope, the Front Range, which is in the middle of the slide, which includes Denver and much of the population centers in the middle of the state, and then the Eastern Plains. This view is filtered by Medicaid as the payer for 2021, looking at outpatient services. And you can see the Denver metro area and most of the Front Range are showing lower average spending per person per year, compared to the rural areas in the East and West with higher per person spending. On the bottom of the slide, we have a breakout of services, and you can see outpatient surgical costs rising over time and then flattening from 2020 to 2021. ED visits is the second line. That's not highlighted. It's the grayed out area. It's the second line right underneath there. But it's dropping from 2019 to 2020 and then coming back up again in 2021. Again, that's the spending component. And again, this is during the pandemic, so much of this makes sense. But it's an example of the tools we provide to HCPF and how they can focus attention on various parts of the state based on those priorities, and again, how they want to filter the various views. HCPF is also very interested in the cost of pharmaceuticals, not just for the Medicaid population, but to Colorado citizens as a whole. Because of the increased cost of pharmaceuticals, state legislation was passed in 2019, which allows HCPF to work with the federal government to implement a Canadian drug importation program. That illustrates how important drug costs are to the state and to HCPF. With direction from them, we've been working to collect drug rebate information. From a policy perspective, understanding how the drug rebate information plays into the total pharmaceutical spend is important because the rebates can make the spending picture cloudy if you don't have that view. In this slide, we're showing the spend over time with rebates factored in and the per member per year spend on pharmaceuticals as a total. And you can see how taking rebates into account reduces the spend by more than 25%. Within our direct analytics contract, we've built in a pool of ad hoc hours that HCPF can use for data and analytics to address unanticipated policy questions. And over the past couple of years, they've used those ad hoc hours to have us pull reports focused on the top 2,000 drugs by volume and by spend so that they can get insights into what that looks like. We also have recently passed legislation for a prescription drug affordability board in the state of Colorado, and some of that information makes its way into the reports that we provide to them as well. Also within our direct analytics contract, we have a project that compares claims data against the hospital discharge data. The cost of hospital care is of tremendous interest within the state of Colorado, both from a Medicaid standpoint and as a general contributor to the healthcare spend across the entire population. High healthcare costs in rural areas take a toll on local businesses, as well as seasonal workers in the mountains and on the eastern plains, and hospitals. Half the hospitals in the state are in those rural areas. Although Health First Colorado has its own payment rates, comparing costs from other data sets to a Medicare reference-based price helps inform policy discussions and provides another layer of transparency when trying to understand which hospitals manage costs well compared to reference points and which ones have charges significantly above the reference point. HCPUF uses the information to help inform policy discussions focused on understanding hospital costs, and again, looking at things as a whole. And so that's been a focus of many conversations and policy discussions, including legislation here in the state of Colorado over the last few years. Anticipate it'll probably be a focus for the next few years to come. As part of our enhancements funding contract, supported with federal and state funds, we created a data mart or data hub that provides HCPUF and Health First Colorado analysts with direct access to the Colorado APCD data. The analysts have seats in our data enclave and have hands-on access to the data sets. The accessible data sets include census and social determinants of health data that provide Medicaid analysts with health equity insights, as well as many other things. They're able to get in there, play with it, filter the data. It's all based on the use cases, which we'll talk about in a second. The data sets we provide are updated semi-annually. There are 13 approved use cases for the data mart. Each use case goes through a compliance review for data use and minimum necessary. And the use cases for the data sets include, again, prescription drug and cost utilization, identifying drugs that can be the focus of interventions to reduce costs. Identifying potential fraud and abuse by analyzing provider billing practices and removing unnecessary costs from the system. Assessing the expansion of telemedicine and its contribution to accessing care and managing chronic diseases. Assessing the support available for oncology care in rural areas of the state. That's just a few of the use cases. There are several others. But in summary, in terms of what's important to Medicaid, or at least what's been communicated to us, data from the Colorado APCD provides HCPUF and Medicaid with a variety of analytics and tools and data sets to help inform their work. In some cases, the data is used to validate what they already know. In other cases, they're interested in seeing how the commercial population accesses and utilizes healthcare compared to the Medicaid population. Again, the view from Colorado is that they use the data more than just focusing on the Medicaid population. They use it to inform policy discussions related to cost drivers of healthcare in general, such as understanding the pharmaceutical and hospital costs, understanding utilization patterns in high-cost areas, such as the rural mountains and eastern plains, and moving us further down the path of health equity. That concludes the comments from CIVHC related to our work with Medicaid here in Colorado. Charles, I'd be happy to pass it over to Erica, or if there are questions, take them whenever is appropriate within the presentation.
Great, thank you, Pete. That is great information, and thank you to Amanda too. I know she was involved in this and mentioned here on the title slide, or the author slide here at the end. So just real quick, as kind of a housekeeping note, let me just ask folks, if you haven't, for whatever reason, this is your first NAHDO event or webinar, we'd love to have you be engaged. So please feel free to put questions into the chat or comments in the chat. You can use the raise hand function. I believe that is under reactions on the button on the bottom of your screen. If you have something to say and want to say it out loud even. So please use those functions. And otherwise, let me get out of the way and hand off to Erica Plante, who I believe, Erica, your title is Senior Health Analyst with, is that correct?
It's Senior Health Data Analyst.
Okay.
At the Institute for Health Policy and Practice. I like saying all of it all together, so everyone gets the whole mouthful. And I believe... Oh, go ahead.
I usually say Institute for Health Policy and Practice at the University of New Hampshire.
Well, yes.
really a mouthful.
I also add in, I technically, for those of you who are not as familiar with IHPP, we have centers that have different names as well. And I'm under the Center for Health Analytics and Informatics. And I also want to say, I am filling in for Amy Costello, if anyone knows that the name is slightly different than the invitation. And she was not able to make it today. So hopefully, if you have any questions that were specific to her, I'm happy to field them. And if I can't answer them, I will definitely pass them along. So let me just share my screen. Okay. Is everyone, can you see my screen, my presentation? Charles, is it? Oh, okay, great. As Charles was kind enough to introduce me, I'm Erica Plante, and I am a data analyst at IHPP. And I get the pleasure of sharing with you some of our projects that we have done with New Hampshire Medicaid data. Okay, so we have a pretty long history of working with New Hampshire Medicaid. 1999, it was DHHS, Dartmouth, and UNH formed IHPP, and there was a cooperative agreement that was developed that has been continued throughout to do data collection, reporting, and analytics. We sometimes refer to this as our core contract. So something in the realm of 25 to 40% of my work ends up falling under core contract, depending on the year. And 75% of what I do right now is claims data analysis. Usually doing projects either directed out of core or other projects that have explicitly asked for work using APCD data. And so this is not the only work that we have done working with New Hampshire Medicaid, but this is kind of some highlights of projects that we have done recently and wanted to share with you. So the first thing that we wanted to share, well, I'll just overview them real quick. We're going to talk about the quality assurance reports. We have a behavioral health Medicaid mortality study. We have a study of mental health in the ED. And then we wanted to highlight our report suite, which is our public facing project. The first three are all sort of behind the scenes and passed between and delivered to Medicaid. Or in the quality reports, which I'll get into in a little bit, are also, we do review commercial data and Medicare data as part of it. So we've been providing quality assurance since 2013. This augments the QA work that Milliman, who is our APCD contractor, we supplement some of that work on our own side. We generate quite a few reports. It looks like a small list here because we wanted to be somewhat succinct about it, but we generally study the demographics, geographic distribution by submitter over time, the PMPM by type of service, place of service, or provider specialty by plan over time. And we also look at continuity and persistency of membership over time. And there are some others that support that, including we do have what we use is the Optum ETG grouper. So we will also do QA work on how that grouper is working between the data and what is being output. So obviously this is looking at eligibility and claims data to see that things are following a logical pattern. And just as for further information, the data that we look at specific to Medicaid is both the managed care organization products as well as the fee-for-service. And this is just a couple screenshots. So I actually do a majority of the QA as part of my role. I have some assistance from a project director who looks at some of the PDFs that we produce of the reports. I personally look at it through a Tableau dashboard that I've built. You can see here some of the selections, but all of those selections at the top are different filters that I can use to look at different things. So I start with an overview of how things look visually and then look for certain types of blips here and there, depending on what it is that I'm looking for. So for eligibility, if there's an unexpected plummet, well, maybe then that's something to dig into with other reports or a further deep dive in QA. And then that's the one towards the back of the slide is just an example of a eligibility dashboard that I get to explore. And then the one towards the front is type of service PMPM. So looking at how is PMPM trending over time. Now this looks like a lot, and generally speaking, I try to parse it down a little bit further. I wanted to give a little bit of a visual dynamic here, but you know, some of the stuff looks cyclical, which is what you would expect. But other times, in fact, you can actually see COVID in April 2020. And I expected, I know it's there because we all lived through it, but something like that, if it wasn't a COVID year, well, that would definitely be something I would have to explore more. Our behavioral health Medicaid mortality study. So we were asked by New Hampshire Medicaid to examine care that preceded behavioral health related deaths like suicide and drug overdose, as well as opioid related overdose. Some of this included an exploration of the linking between Medicaid claims and vital records, and producing some rates around that. The second part of the project was looking at the actual decedents and looking into their claims and seeing what types of treatment they had, mental health treatment specifically, prior to their death. And so the eligibility criteria for this analysis included having a state-assigned Medicaid ID, full Medicaid coverage, and Medicaid coverage within 10 days of death. From 2014 to 2021, over almost 110,000 death records were identified. And then we linked the death records to the Medicaid eligibility records and calculated adjusted mortality rates for each of the decedent groups by cause of death and compared Medicaid to non-Medicaid rates. So the graph is that this is a simple graph, but it gives you just an idea of some of the things that we were exploring in the first component of this. And I believe we have produced a report from this that will be delivered to New Hampshire Medicaid, probably will not be released publicly. We've been given permission to share this, but it has a few more details about each type of death and what the rates are. And we have Medicaid versus non-Medicaid. So this graph shows the rate per 100,000 for drug overdose, opioid related. Probably comes as no surprise to anybody here that this is an important subject matter in the state of New Hampshire. It's an important subject matter all over the country, but this project was started prior to the COVID pandemic, and when New Hampshire was really, really high on the drug overdose death list. I think we're probably still up there, but I think at that point we were number 3. And so you can see there's a clear relationship between the Medicaid population and the drug overdose opioid death rate. So for 2021, the adjusted death rate for all causes of death for the Medicaid population is 3 times higher than the non-Medicaid population. Similarly, the death rate for unintentional deaths is 3 times higher for the Medicaid population than the non-Medicaid population. And the drug overdose opioid related death is more than 6 times higher in the Medicaid population than in the non-Medicaid population. And then from 2014 to 2021, the death rates for all causes of death by all unintentional deaths for both Medicaid and non-Medicaid populations increased by approximately 11%. However, the suicide rate for the Medicaid population increased more than 26%, while it decreased for the non-Medicaid population by nearly 18%. And since 2014, the drug overdose opioid-related death rate has increased by more than 78% for the Medicaid population, but decreased by 19% for the non-Medicaid population. We don't necessarily make any sort of inference about why it's happened. This is the point of the report, is to pass along to Medicaid, and they can make some of those conclusions. Second part of this, we built another dashboard using claims data, looking at just the Medicaid decedents and trying to understand what types of treatment, if any, occurred prior to their death. I believe we looked back 6 months prior to their death. And so this is just an example. It is a dashboard. So there's all the different filters are to the left. So we were able to look at years. This is all over the all years that we were looking at, so 2014 to 2021, and then the different causes of death. We also parsed it out as were they dual or non-dual eligible with Medicare. Did they only have Medicaid in the month of death? Which was an interesting question about that relationship. Again, you can have some thoughts about it, maybe make some conclusions about that. We just simply provide the data. And then the treatment status, and there was a question about whether evaluation and management should be included as treatment. So we do give the option of turning it on and off, and also allow New Hampshire Medicaid to look at it by age group, and then county and sex. As you can see, not a lot of treatment actually happening. I guess I'm not clinical, so I don't know what would actually be considered a good amount of treatment. But you know, for the non-duals, it looks like, you know, they had the first, so almost 50% had no treatment whatsoever prior to the 6 months prior to their death. So that's kind of something that Medicaid can take and use possibly towards any sort of policy that they're trying to work on, or interventions they can work on, things like that. And then this is another version of it. So this is, oh, and I apologize. This was for drug overdose, and then this is for suicide. Again, the no treatment was over 40% for the non-duals, which is a majority of this population. I should probably say that. As you can see, there are some suppression points here. So it's, you know, it's a pretty, it's not a lot of people are I mean, it's still 40, so I guess 60% are being seen, but you'd still want those numbers maybe a little bit higher before things happen. And then parallel to this, we also did a study of the mental health related visits to the ER. We wanted to understand the rates of visits to the ER for mental health conditions, as well as patterns prior to and following those ER visits. Well, not necessarily the different population in some cases, but different projects, not necessarily linked in any way. But they do have an interesting parallel, right? So this is just a visual example of one of the reports that are in the dashboard that we provided. So it's a rate per 1,000 members with at least one visit to the ER for mental health conditions in 2021. And these were all conditions selected by New Hampshire Medicaid that were of interest. This project actually came out of a lot of policy discussions about the ER boarding. We had a lot of ER boarding in New Hampshire a few years ago because there was a lack of beds throughout the state. I think we still have a lack of beds. But so those conversations came to this point where we're like, we need to understand what is happening in the ER and happening for treatments before and after. Similar structure where we offer them the filter so they can look through it in different ways. And this also gives a comparison between commercial and Medicaid. It actually includes Medicare in here, but this slide is for 2021. So we didn't have at the time data for Medicare through 2021. So it's not in this visual, but it is in the dashboard. And then this is just another example of the treatment prior to visit. So those who had mental health treatment 6 months prior to an ER visit. And we do have the different mental health disorders, so they can be toggled through. So if they just wanted to look at depression, we can look at just that. And then also, did they have an inpatient stay as well? And these numbers kind of looking in parallel to the behavioral mental Medicaid mortality study are interesting because they're very high. You know, than what you would expect in terms of having treatment prior to. And this is any mental health treatment, and we worked with Medicaid to select what that meant. The other things that we've explored in this dashboard is how often were the CMHCs utilized, because that's, you know, different for different populations and different age groups and such. And then last, I wanted to touch on the report suite. Now, this one actually has a few other funding sources, but it's very much a great resource and is supported by New Hampshire Medicaid as well. So this is our public facing report suite. We basically provide all of these different reports for commercial Medicaid and Medicare, except for dental, because we don't have, there's no dental Medicare, but these reports are all available publicly online with data that's downloadable, filterable for different variable options, and then it can be used. And some of you may have even seen the data and didn't know it, or did know it, because Joe Porter was my super user of this these report suites, and has helped build them over the years through her feedback and inspiration. So, you know, you may all be aware of some of this in here, but just wanted to highlight, this is an example of the ETG report. It's episode treatment groups. This is the grouper that I mentioned earlier in the presentation. It's somewhat similar to something like a condition. The grouper basically groups episodes for diagnoses and procedure codes into episodes of care. So things like diabetes or broken arm and such. So this particular report has a breakdown of 4 years that allows you to look at the top 10 most common ETGs based on member months for New Hampshire Medicaid members. And as I mentioned earlier, there's filters that allow you to filter it by, you know, age group, county, sex, and then in some circumstances, there's further options depending on the report. And I just blew this up a little bit to show that A, you can kind of look at it closer, but also part of the report function allows you to blow up, expand the chart so you can see it more closely and download it and use it in a presentation. And the filters are shown down here as to what you chose. Also, in all of the reports, there's another page that puts all of the data into a cross tab that is downloadable into an Excel spreadsheet. And the Excel spreadsheet is set up in such a way that you can do your own visualizations using Excel's pivot table function or what have you. And I invite you all to check out igpdata.org. It has the report suites, but also has our HealthWorks module, which is the New Hampshire BRFSS module. All right, and this is our team. Amy, who unfortunately couldn't make it today. Chris White is our operations manager. I'm a data analyst, and Bethany is our amazing project director. And if anyone has any questions, you can also email me. I'm Erica-Lynn.plant@unh.edu, and I can put that in the chat too. Thank you.
Thank you, Erica. Please do, if you don't mind, toss your email in the chat and see that there. So as I mentioned a minute ago, and as you're seeing now, you can put questions or comments in the chat, but this is an opportunity to kind of ask any questions that you have for our presenters today about the data or their relationships to the Medicaid programs. If anyone has a question, you could probably just come off mute or raise your hand if it makes you feel better, or toss them in the chat. And I wrote down a question to kind of get us started, or a couple of them. So maybe I'll just jump in here. So I'm wondering, I'll try to ask this question a little bit broadly so that maybe both of you could speak to it, but I'm wondering about, you know, how some of the known limitations of, specifically I'm thinking of, I guess these aren't entirely applicable to claims data, but some of the known limitations of the claims data or of these data affected analyses, or affected maybe, you know, did they come up with Medicaid at all? And what did you all do about them? And when I say some of the known issues, I'm thinking of, you know, the lack of self-funded data. Does that have an impact on how Medicaid views the comparison to the rest of the market? What about, you know, we were just talking a moment ago, Erica was mentioning the you know, behavioral health and mental health. Well, what about limitations due to, you know, the interpretation of data suppliers of SAMHSA's rules limiting the re-release of substance use disorder related treatment data? And so, yeah, those are just a couple of examples. And I'm wondering how, you know, what, if Medicaid said anything about those things, and how are you all working through them? Or, yeah.
Happy to share the experience from Colorado. Yes, those things do impact how the data is viewed. On the self-funded side, we work in partnership with the state and with other groups to try to bring in as much of that as we can from a voluntary basis. We've made small improvements. We'd love to make major steps forward. We run into some issues with some of the contracting processes through the TPAs and the ASOs, but we're very much supported by the state in trying to do that. The state views the data set as the more complete we can make it, the more accurate it is, the more we have the confidence in it to actually leverage it for some of the policy discussions that we have. But it's a recognized limitation. And when we look at things, we try to caveat things and put the appropriate considerations in place when viewing all the information. On the SUD side, that's a great question. We're still working through some questions with the state in terms of the recent interpretations of the changes to 42 CFR Part 2. We do get SUD data. I think there's some questions in terms of the completeness of that, and then how we can actually or should be intaking it as well as releasing it back into the marketplace. And so at the moment, we're in conversations with Medicaid currently, both from a data usage standpoint, as well as more of a legal conversation in terms of what's appropriate based on interpretations of those recent changes. And so we've put a pause on things until we work through all that with the SUD side of the conversation.
But yeah, and I would say pretty similarly, we do acknowledge a lot of the limitations, like the self-funding. I will say with Medicaid, the data itself, like, you know, we do a lot of our work parsing out everything separately. So you're right, comparing to commercial can kind of get a little funky when you don't have the self-funded in there, right? So I think it's just something we've been acknowledging for so long that it's almost become, you know, intuitive. Regarding the SUD, I would have to look into that more about like what is the relationship there. I haven't seen anything quality-wise that was concerning in terms of like things looking strangely, but that's a great question to take back to our colleagues. And then other limitations that we do run into, I would say one thing that I think is always a really critical part of designing any of these studies is clinical feedback. Picking what is considered treatment is actually a little bit more complex than, you know, what it might seem at first, or choosing what diagnosis codes to include in our studies, like what is a mental health in the ER condition that we are interested in? Does it include anxiety? Does it not? So, you know, it's not a limitation in the sense of like the data isn't available, and more that the data doesn't give us any information other than a diagnosis code and some other stuff. It's, you know, a billing code. And, you know, how do we say something is clinically one thing using claims? So we do kind of work with the state quite a bit and trying to align ourselves with what they have for choices that they've already put through review. So for example, in the Medicaid mortality study and the behavioral health and the mental health and the ER study, we completely leaned on lists from them. We took the diagnosis codes they wanted and recommended, and whatever categorization they wanted. So for the ER study, they didn't want anxiety to be its own category. They wanted it grouped with other things. So and then like they selected what was called a mental health treatment. So that's something that we have to work through a lot. I think that takes a lot of time in the beginning of the study. But luckily we have a great relationship that we can do that with them.
have.
I just echo what Erica just said about the relationship with the state and with Medicaid in general. When these questions come up, we've tried to build a foundation so there's a broad understanding across the board in terms of how the data can be used and what some of the limitations are. And the more we do that, the better understanding we have, not just with our state partners, but with anybody else who uses it. And it makes for a really good dialogue when new questions come up that we can rely and trust each other to dig into whatever that question is, and then work through it together to find, what's the appropriate way to manage whatever the issue is that's been called out. And would add one more thing to that. We have a great partner in our data vendor, HSRI. We work very closely with them to look into these types of questions as well. They have been fantastic, and we rely on them a lot to help address questions we may not have the answers to when we really dig into the weeds.
Oh, and one thing we also
more endorsement for relationships.
Well, yeah, I actually am like, I'll build off that too. One thing we do with our QA reports, as well as when we have a finding, we bring it back to the state to, if it wants to be dug into more, great. If it's not, that's fine. But we just want to, share. We don't withhold any of that information by any means.
Both. Yeah, I'm hearing the importance of relationships and transparency, which is relevant almost always. So that's great. Yep. So just one more plug for questions, comments. Anybody? I break here for a moment. Feel free to put them in the chat still. So another thing I'm wondering about is I realize that there's a way that this does kind of happen when in certain reporting that risk adjustment might be baked into it. So for example, you showed the ETGs, Erica, or I'm sure there are other groupers that would kind of have that effect of doing something like a risk adjustment. My question is though, is Medicaid, are they interested? How are they interested? How does that the risk sort of factor into the information that you all are sharing back with them? For example, this seemed really relevant when we were talking again about behavioral health mortality a moment ago. It's like those, and I, in my experience doing some of these analysis projects, I know that you very often can go in front of your review committee or whomever made up of often stakeholders represented in the data, and no offense to any providers on the line, but often the providers will say my patients are sicker, or there's some exception or reason that this is true. That makes enough sense to me that might be true. The Medicaid population is a distinct population. So do they ask questions about these? How does this come up, and how are you all addressing it?
I'll just go. And my knowledge on that question is somewhat limited. I am not hands-on in the data. But we do have risk adjustment baked into the data at one point, and this is a conversation. I don't recall how this actually, the outcome of this, but there may have been some risk adjustment built into the data that we were receiving from Medicaid. And we had to go through a conversation as to, if you're already doing it, should we be doing it as well? Or should we just be relying on what you already have? I honestly don't recall what the outcome of that was, but it was an important question, and we did dig into it. And I'd be happy to follow up on that and find out exactly how that played out. But it is an important question.
I agree. I think, given the example of like the report suite, we do not dive into level of severity with the ETGs. There is, that grouper does have some, that it also has a severe a risk adjustment component to it as well. We haven't had any that I have been part of conversations about that. We do, generally speaking, when we talk about commercial and Medicaid and Medicare in the same space, we're very upfront with like, this is the parameters of who was in this study. This is who we kept, and this is what the population looks like. That report suite, I didn't highlight it in this presentation, but every single section, the medical, the pharmacy, and the dental all have an overview. So you can go to that page and see what is the makeup of this population that's in this report suite. It's incredibly important to know what you're looking at. And maybe that's a great feedback point though, to think about of like, are we saying explicitly in the report, like, hey, these are different populations. When you're comparing them, you need to understand that, you know, they're going to have different risk factors. And yeah, so it's a great notion of like kind of next steps to talk about with our colleagues.
Well, last call for kind of questions and answers here. Let me say thank you to both of you as presenters and speakers for sharing this information. I will make a little bit of, you know, just I guess a plug, so to speak, and just mention that we've heard from a couple of programs kind enough to share with us the work that they're doing. I think it's fair to say that most, if not all, APCDs have some type of relationship, especially on the APCD side. On the hospital discharge side, it probably varies a bit more, but on the APCD side, most folks have relationships with their Medicaid programs. And so these are a couple of examples, but I'm sure that there are others. And so I would encourage everybody to, you know, obviously kind of stay in touch with each other, reach out to me if you have questions about what others are doing, reach out to us here at NAHDO, and we'd be happy to try to follow up on those. And so, yeah, without further ado, I'll say thank you all again for joining us today. And we look forward to seeing any of you who might be available to join us in Boston here in a couple of weeks in mid-August. And until then, or if we don't see you then we'll have another Hot Topic webinar is scheduled for September. And so I will see all of you then. Thank you. Take care.